Hello everyone, I am Dr. Santosh Kumar, Founder and Director of Momentum Orthocare, Kolkata. Momentum Orthocare is a dedicated team of orthopedic surgeons and other healthcare professionals wherein we are determined to provide the very best of orthopedic care and very best of joint replacement surgery, especially knee and hip, to our country at the most affordable prices. So before this, we had several educational videos in which we have discussed several of our orthopedic issues. So today we will be discussing problems pertaining to the hip joint. Hip joint, as you know, is the biggest joint in the body. It's a ball and cup joint. Like if you see the structure, this is our spine. This is our spine, and where the spine joins the pelvis, where the thigh bone joins the pelvis, there is a joint called hip joint. So this is the hip joint, and this is the biggest joint in the body. It's a ball and cup joint. Like if you see the structure, this is the thigh bone, which is known as the femur. This is the neck of the femur. This is femoral head, and this is the cup, or known as the acetabulum. And so this is the hip joint. It moves like this. We sit because of this joint when this joint folds. We walk when this joint is straight. And this joint is the largest joint in the body. And of course, it is very, very important. Now, hip joint is subject to several problems. Some of them are because of fracture or trauma. Some of them are atraumatic. And problems of hip joint are very, very common, especially in this part of the country where ankylosing spondylitis, the diseases of hip joints like ankylosing spondylitis, avian are pretty common. Now, to assess this, we must understand that this is a living joint. It's a biological joint. It has got its own blood supply, and the blood supply comes via the neck. Like this is the shaft of the femur, this is the neck of the femur, and this is the head of the femur. The blood supply comes via this neck, and it supplies the head as well as the acetabulum. Now, this hip joint is, as we discussed, is subject to various problems. Some problems occur specifically more in the elderly, like neck femur fractures, and some problems occur more in the younger population, like ankylosing spondylitis, avascular necrosis, etc. We'll see one by one. Luckily in India, primary osteoarthritis of hip is rather less, and most of the problems that we get is ankylosing spondylitis, avascular necrosis, or fractured leg femur. Now the issue with hip joint is that it is a very, very disabling problem. The pain because of avascular necrosis in the hip joint is very, very severe, whether it is ankylosing spondylitis, avascular necrosis, and fractured neck femur leads to complete disability on the bed. It doesn't allow a person to move. Any hip pathology leads to far more disability than any other joint pathology. The pain in hip is more nagging than the pain in knee or any other joint. It disturbs the activities of daily living, including walking, sleeping, sitting. Even the pain is there is sitting and sleeping also. So first to understand what is hip pain. Hip pain is essentially felt in the groin. It is not in the buttocks. Like if you see the joint, this is our structure, this is our backbone of the spine, and the backbone pain is felt in the buttocks, and hip pain is felt in the groin. So I see a lot of people who have pain in the lower back and buttocks, they say it is hip pain. Pain which is present in the lower back and the buttocks is essentially pain from spine. That is not hip pain. Hip pain is always in the groin, thigh, and it goes towards knee. Whenever there is a hip pathology, hip problem, the pain in hip is in the groin. It is in the thigh, front of the thigh, and it goes to the knee. So this is the typical pain in hip. The pain which is there in the buttocks is not hip pain. It is from the spine. It is from the facet joints of the spine. Now to start with, the pain is in groin. It goes to the front of thigh and knee. There is antalgic gait. What it means, there is some painful limp to start with. And it is more in, the pain is more in walking, climbing stairs. Then gradually, as the painful limb keeps on progressing, there is shortening on the affected side because of hip pathology. The limb shortens by 1 centimeter or so. And then there is gradually difficulty in sitting in chair, and then the pain becomes nocturnal. What it means is that there is night pain also while sleeping also. It gradually disturbs our activities of daily living. So that is the biggest problem of hip joint pain. Now, once a person with hip pain, that is groin, thigh and limb, painful limb comes to us, we do clinical assessment, which includes a range of movement, pain while moving the limb and limb length discrepancy, that is difference in the length of the limbs. We measure all these things and we do an X-ray. So this is how a normal X-ray looks like. This is the pelvis, this is the right hip, this is the left hip, and there is a congruity. There is a congruity, ball and socket joint with a congruity. We nowadays do digital X-rays in which there is a software in which we can measure the length, inclination, the size of the cup, ball, everything. So these are the newer digital X-rays that we have been doing. Whenever there is a problem, for example, where there is a fracture in the neck femur, like fracture neck femur is of two kinds. One is intracapsular, which is inside the joint, and another one is extracapsular. Once it is extracapsular, we try to fix it. Intracapsular also, if it is reasonably early, and if it is a younger patient, we try to fix it. Sometimes it is late and fixation is not possible in fracture neck femur. Like we see in X-ray, the right side has got fracture neck femur, left side is normal. So left side is normal and right side has got fracture neck femur. So we try to fix it. Initially, we try to fix it with screws like this, multiple screws. We try to fix it. We may try to fix it. And several times it is successful. Fixation is successful. But if the age is more, there has been delay in treatment. More the age, less the chances of healing. The more the delay in treatment, less the chances of healing. So in that cases, fracture fixation may be difficult. Sometimes subcapital fracture fixation may be difficult. And even if the fracture heals or doesn't heal, even if it heals, it may get into avascular necrosis. So the word avascular necrosis means disruption of the blood supply of the femur bone, the disruption of blood supply at the head of the femur leading to death of the cells, that is decay in the head of the femur. So we several times fix like this, and several times it may fail. This fixation may fail several times. So this is how we see in X-ray. There is a fracture on the right side. The lower the site of fracture, more likely is the union rate, and higher the fracture in the neck, the less likely is the union. In that case, we may need to do hip replacement. And if the fracture fixation fails, we have to do hip replacement. If there is avascular necrosis, even after the fracture is united, we have to do hip replacement. Now, X-ray is the basic tool. Once we assess, X-ray is the basic tool. Like this side, you see this is the normal femoral head, and this side is the arthritic femur. There is severely narrow joint space. There is incongruity. There is severely narrow joint space. There is sclerosis. All these things we detect in X-ray. Sometimes in very early stages of arthritis or avascular necrosis, X-ray may be normal. In that cases, we need to do an MRI film. So this is an MRI film wherein we have seen the signal changes right in the early stages of avascular necrosis. It is several times important to do MRI in early stages of avascular necrosis, because if we detect in early stages, we may preserve the joint. So it is important to do. Sometimes in X-rays, we see the joints are completely fused because of ankylosing spondylitis. Like we can see, this is an X-ray of ankylosing spondylitis, wherein the joints are completely fused. And in that cases, we need to do joint replacement to restore movement, painless and stable movement. Because once the joint is completely fused, person will not be able to sit in chair also, leave of walking, and it is fused in a particular angle, creating severe disability. So we need to do joint replacement to make it mobile. Discussing our X-ray findings. So this is what we see in X-ray. There is incongruous sclerosis, reduction in joint space, and all those things we see in X-ray. Once the changes are visible in X-ray, that means the disease is already advanced. Like this is the arthritis which is already advanced, and we need to do joint replacement. In extremely neglected cases and extremely severe cases, we can see pictures like this wherein the joint has completely vanished and we need to do joint replacement. So basically, to understand joint replacement, what we do, we remove this femoral head, the ball and the cup, and we put a new joint ball and cup over here. So this is known as hip replacement. Nowadays, we try to do with minimally invasive approach. So these are the minimally invasive approaches in which we do through minimal incision. We try to make it stitchless, and no stitch will be there. The person will be able to take bath after 3 to 4 days of surgery. There is no stitch removal, so we try to make it minimally invasive. But there are multiple approaches to the hip joint. The approach that we decide is based on our expertise. It is based on the type of deformity, that is the bending of the hip, the type of pathology. But basically there are few approaches which include anterior approach. Direct anterior approach has become very popular nowadays because of better gait. So gait, we'll discuss what is this gait. There are approaches: anterior, anterolateral, direct, lateral, posterior, and of course we do through minimally invasive approach. So gait is the way person walks. Once there is a hip pathology, there is a painful gait. The patient walks with a painful limb, and there is a lurch while walking. What is gait? Like a duck. So we do hip replacement. We try to bring the gait as far as possible to the normal. So we have to preserve the muscle function. In that case, we choose our approach as minimally invasive as possible. We may choose direct anterior approach. We may choose anterolateral approach. We choose all these approaches to make the gait, that walking normal. Walking normalcy is very important. This is, we choose the approach based on that. So this is what is basically hip replacement. This is what is basically hip replacement, and this is the normal side X-ray. This is a replaced hip. So just to understand what is this hip replacement, this is the hip replacement implant. This has got a stem. This is a head which is modular. It is and this is the cup. The outer lining is generally rough coated, porous coated, so that bone ingrows on that, and inside is generally ultrafine molecular weight polyethylene, and the head is generally ceramic. Sometimes it can be called chromium, and this stem that is fixed can be cemented. It can be put with bone cement, or it can be uncemented. Uncemented means it will be a pressed split, it will be a scratch split, and bone will ingrow on this. So normally nowadays we use a lot of hybrid systems in which the cup is uncemented and stem is cemented, but we can choose cemented or uncemented stem based on the situation. There is no way to say which is better, but it is based on the situation. And of course, cup mostly uncemented ones are better. Now to understand how these uncemented cups work, basically the implants are rough coated, and the bone engrows on that. So there is the implant surface with porous layer, and the trabecular bone grows into that. So bone growth fixes the uncemented implant, and in cemented implant, thus bone cement fixes the implant. And for example, this is a very beautifully done hip replacement. We measure the limb length based on this, and limb length is restored. So the goals of hip replacement is to get painless and stable movement and to restore the limb length. Normally arthritic hip is shortened, and there may be limb length discrepancy and difference in limb length, and we restore the limb length, and we improve the gait, we improve the lurch, we remove the pain to make the gait normal. So in normal hip replacement, the ball, the head and the cup is replaced with a new ball and a cup. Several times, especially earlier on, we had tried resurfacing, in which only the surface was replaced, the whole ball was not replaced. This is known as hip resurfacing, also known as Birmingham hip resurfacing and all. But presently this hip resurfacing has been withdrawn. Mostly it is total hip replacement. And in total hip replacement, we have got multiple innovations, multiple newer things. One of the newer things that we are doing, we will see again, is robotic hip replacement. This robotic hip replacement is more of a navigation in which the cup is placed exactly as per the landmarks, as per the anatomical landmarks, and the precision that matters. In any joint replacement, it is the mechanics, it is the precision that matters, and in this, it is placed as per the landmark. Presently, we are using mostly ceramic on poly. The inside is highly cross-linked ultra-high molecular weight polyethylene, and the head size have been increased to 32 or 36 millimeter. It is ceramic on poly. So this gives, the higher the head size, it gives better range of movement. And along with this, we have concept of dual mobility, in which there is two movement. There are two movements. One is at the junction of the head and the polyethylene, and the one is the liner also moves. To understand this, this is the cup liner. So there is a liner inside that. There is a ceramic head, and on top of that is ultra molecular polyethylene. So this is known as dual mobility cup. There is a movement over here and there is a movement over here. So what is the advantage of dual mobility is that it increases the head size further. The bigger the head size, more is the stability, more is the movement that we get. So to understand, the bigger the head size, the more is the range of movement and more is the stability. Bigger the head size, more is the range of movement and more is the stability. But dual mobility hips are not used universally in all cases, because still large head ceramic on poly is the standard. Whenever we suspect weak muscles or we suspect higher age, we use dual mobility cups, because dual mobility cups provide better stability, better range of movement, but the surface is moving at two surfaces, two sides, and it may increase the wear rate also. And so it is not used in young patients, it is used in older patients with lesser muscle power or risk of dislocation. Now, the most of the common problems that we get regarding hip is, one is fracture neck femur, which we have already discussed. Second is ankylosing spondylitis, and third is avascular necrosis. So second, in fact, is avascular necrosis. We will understand what is this avascular necrosis. As we saw, the femoral head has got a blood supply like this. This is the femoral head. There is a blood supply, and this blood supply may be hampered because of various reasons. This blood supply in the femoral head can be hampered because of various reasons. One of them is, for example, fracture. Second is alcohol abuse, steroid, and several times without any reason, wherein we cannot find out why the blood supply has been hampered, and this leads to arthritis, which is known as avascular necrosis. So this avascular necrosis causes pain in the groin, thigh and knee. There is intermittent pain, limited range of movement, limping, difficulty in climbing stairs, standing and walking. So the solution in this case, in early stage 1A, there is a classification based on staging 1, 2A, 2B, 2C, 3. So stage 1, if we can detect, we can try stem cells, we can try regenerative therapies, but once it is beyond stage 2B, we have to do hip replacement. That is the only predictable thing. Another pathology that we get is ankylosing spondylitis, especially in the eastern India, this part of the country. Ankylosing spondylitis, wherein this is a genetic issue in which the spine and the hip joints, sacroiliac joints go into inflammation. To start with, there is severe pain or movement, and then it gradually fuses. It affects the spine, it fuses the spine, it affects the sacroiliac joint, and then it affects the hip. In that cases also, we have to do total hip replacement, because total hip replacement will restore painless and stable movement. And just to understand once more the concept of dual mobility hip, like in normal hip, the movement takes place at one place only. In dual mobility, this moves as well as this moves. So this one is moving, the head is moving, the liner is also moving. The head is moving, the liner is also moving. So this gives two places of movement. This gives two places of movement. The head is moving, the liner is also moving. So this gives two dimensions of movement. It has got a head, it has got a liner, head moves inside the liner and liner moves inside the shell. So this gives what is known as dual mobility hip. Now as we saw, dual mobility hip is better in certain situations but not universally well, because things are still the large weight ceramic on poly is supposed to be better, and dual mobility is very good in certain situations. The stems can be cemented or uncemented. The stem that we use, it can be cemented or uncemented, and cup is mostly uncemented. They are all very high quality titanium or tantalum porous coated cups, and they are fit with to the bone, and then stem can be uncemented or cemented. Presently we use porous coated cemented stems. For better accuracy, we use our robotic arm. This is our robotic arm. We have the QVIS robot. We use the robotic arm for better accuracy of placement of implants. Now this is the robotic arm. This is the robotic arm, and we do robotic hip replacement. So the benefit of robotic, this is the robotic arm. This is the robotic arm. This is the console that we do. This is the console that we do. And the benefit of robotic hip replacement is first the surgery. Before the surgery itself, we know the placement of the implant, where we are going to put. We know the sizes of the implant, what size of implant we are going to need, and that whatever we plan before the surgery is just executed and copied during the surgery. So that gives enormous accuracy, all possibilities, probabilities, and various options, and makes things very, very predictable. So that is the beauty of robotic arm hip replacement, and it works through minimally invasive approach. Minimal cut is done. So we are routinely doing this, and our patients, like several times, we do bilateral hip replacement. We replace both hips in the same sitting. Sometimes we do unilateral, they base the patient to patient. And if the patient is younger than 50 years, we do load a lot of them, both hips if needed, in the same sitting. For example, this is the bilateral hip replacement. This is a patient who had come from abroad, and the patient walks from the very next day of surgery. And we have been using this robotic hip replacement routinely, and this has given us better results. It is my request that if anybody of your friends or family needs orthopedic surgeries like joint replacement, hip replacement, knee replacement, you are welcome to Kolkata. Contact us, give you the best, the latest and the most advanced on this earth at the most affordable prices. And you need not be going abroad for this surgery. Whatever the best is available on this earth is available right at your doorsteps in Kolkata.